Welcome everybody to session 94. Today we're going to be doing a PA spotlight on psychiatry. We're going to, next slide. All right, here are our upcoming sessions. Next Tuesday, we're going to have a nurse practitioner spotlight. On the 19th, we're going to do a radiation safety expert session. And on the 26th, we're going to be talking about patients dealing with chronic pain. Make sure you join us on Zoom or on YouTube Live at 7 p.m. Central Standard Time. Next slide. Here's our working group. Thank you everyone for helping us come back from spring break. And next slide. And we're going to have two Q&As as usual. We're going to have one in the middle of the session and one at the end. So just make sure you ask your questions on the Zoom chat. We'll go ahead and relay those to our presenter in the middle of the presentation and at the end. Before we continue, Dr. Fowler, do you have a couple of words?
Yeah, it's so nice to have you all here. Welcome, everybody, all the way from Pakistan to Thailand and all parts around the world. It's so good to be back with you. I'm glad to have you here after a couple of weeks of spring break. We needed a break, and I know that you did too. So it's really great to have you. This is virtual shadowing. Virtual shadowing has become kind of its own entity. Namely that it appears that admissions committees are paying attention to online clinical connection, if you will. And it looks like virtual shadowing is one that has at least gained some reputation. So we're really awfully glad to have you here and hope that you will keep coming back. And tonight we have a really exciting guest. And Ali, would you take the moment to introduce our wonderful guest for the evening?
I would love to. We can go to the next slide. So today we're going to be talking about psychiatry and addiction medicine with our presenter, Rashada Jordan. She is currently a physician assistant, currently working here in Texas. I know that we have a lot of PAs that watch our virtual shadowing presentations, and it's really great that we finally have a PA to come here and talk about her experience and the experience of getting into PA school and the day-to-day activities of becoming a physician assistant. So I'm really excited for today's talk. Ms. Jordan, you can continue.
Yes. Hey, welcome everyone. I'm so excited for this opportunity to be speaking with you all tonight. Psychiatry and substance abuse is something that I've had almost 4 years of experience doing. I will get into my story and how I ended up in psychiatry and more insight into what a day in the life looks like. But first, I would like to, of course, give a disclosure that this is for educational purposes only. But yeah, let's just jump into it. So my background. So education. I started out at Coastal Carolina University in 2016. If I have anybody from South Carolina in here, hello. And then right after I graduated from Coastal Carolina with my Bachelor's of Science in Public Health, I went right into Francis Marion University for my PA program that I got accepted into. So a lot of people ask, because they see like, 2016, and then I turned around 2 years later and graduated. Yes, I went right into school and I did not take a gap year. Looking back on it, do I think that was crazy? A little bit. PA school is rigorous. It's a lot of information. If you've been doing research on PA school, or if I have any PAs on tonight, I'm pretty sure we have all heard the saying, it's like drinking water out of a fire hydrant. So definitely, I do wish to an extent I would have took a gap year, but looking back on it now, I don't think I would change anything because that would probably mean I'll still be in school. But after I graduated from Francis Marion University, I forgot to mention, I just graduated in January with my doctorate degree in medical science from University of Lynchburg. And I'll talk a little bit about that as well. So like starting from like the very beginning, when I was going through my undergraduate degree, before I even graduated, I was already making preparations to go into PA school because I knew ultimately that's what I wanted to do. I already had my mind made up. So I didn't have to do post-bac. I don't know if some of you heard of post-bac. It's like, of course, you graduate or you have to go to another school or another college or community college to take the prerequisite courses or you're retaking classes that you didn't do so well in to get a higher GPA to be able to apply to school. I didn't have to do that, thankfully, because school is already expensive enough. But like from my freshman year, I was already making moves to go straight into PA school. So I had already picked out my 5 programs that I was interested in, because there's a lot of programs that you could pick from, but I just wanted to do a top 5. I knew that my options were wide. Like I had a variety of options to choose from because I didn't have anything holding me down or holding me back necessarily. And I didn't have like a cap or a limit or any place I wouldn't go or I wasn't interested in. I just wanted to go to PA school. But before that, after I picked out my first 5 schools I was interested in, because every school prerequisites is different for PA, I had to make sure that I took the GRE and I had to make sure I understood what that was and how to prepare for it. So going into GRE prep, a lot of people don't know that your scores are good for 5 years. And if I had known that, I would have started taking the GRE my freshman year. So if you're early on and you know you want to go to PA school, you're interested in it, I would recommend taking it as early as you can so you can have more time to retake it if you need to get the highest score possible that you can get. And the resources that I use to prepare for the GRE would be Magoosh. Magoosh is a website. I'm sorry that didn't show up more. It's white on white, but Magoosh is a website and it's an app. So I use the app on my phone and I would be answering like math questions, reading questions while I would be sitting with my mom while she's getting an oil change or standing in line at Walmart or Target and just going through things really quick. No, it didn't matter where I was. That helped. And also GRE for Dummies. So I know people can be taken back a little bit by the title, but I'm pretty sure everybody has at least heard of the For Dummies collection at some capacity.
So Rashada, it's Dr. Fowler, Ray Fowler.
Yeah.
What made you decide to go to PA school rather than medical school or nursing school or NP school? What affected your choice?
I would definitely say when I was in 8th grade, I was in a pre-med program. And we would meet every other Saturday and we would have other speakers come in and speak, and they had summer internships and other things. And one day we had a PA come to speak. I was MD route. I was pre-med route. I wanted to be a pediatric cardiologist and I was going to fix all the little babies' hearts. And then this PA came, and she spoke to us and she told us about what she does and how long she went to school and the versatility of the profession. And I said, I think I want to hear more about this because the time is less, the debt is less. Let me go and talk to her. So I got her contact information and I did my own research and I compared and contrasted the two. And I just felt like PA was the right route for me as far as time goes. I'm like, I still want to have a family. I still want to have a life. I don't want to blah, blah, blah. No disrespect to anybody going to medical school. We need doctors and all that. But that was just the best choice for me. And so after speaking with her, I made that choice. And then that changed because I was like, well, if I can go into any specialty without having to go back to school, then I mean, I can still be interested in cardiology. And then if I get sick of that, I can go to geriatrics, or I get sick of that, I go to, so I was like, okay, I'm interested in that. So I guess those.
Rashada, I've been on the admissions committee at UT Southwestern now for the medical school for 10 years.
Yeah.
And when we started virtual shadowing 2 years ago, I thought it was going to be really all about pre-med virtual shadowing. And what has been astonishing to me personally and professionally is that it's become very much a pre-PA program. I didn't realize that. And I didn't realize also that what you just said was the point, is that it's shorter, there is less debt involved, and there's less educational commitment involved and so forth.
Yes.
And so firstly, we're just delighted to have you here because you are the most popular presenter of almost 100 lectures that we've had, and so we would like to, please go on, but to hear more about why you took the PA route, and now that it's working out for you, are you glad you did it in this era of burnout,
Uh-huh.
20-30% of all medical professionals quitting right now. Are you happy doing what you're doing? Keep going. Please keep going.
Yes. Okay. So, well, now I want to answer your question. So I would definitely say, yes, I love what I do. I love what I get to do. That's what I say every day. I love what I get to do. I definitely say PA school, like in learning any type of medicine, no matter what area of medicine you're in, is tough. It's rough. Like there's plenty of days where I wanted to quit because you're learning everything doctors learn in less amount of time, because we were created to be mid-levels to help fill in the gap for the physician shortage. And now we're just out here. So, I mean, PAs have escalated, especially during the pandemic. There has been some states that waived the right for us to have to work with a physician and all these things. But I think what I enjoy the most about being a PA, besides the versatility and the money and all this other stuff, is just the connection I get to make with my patients. And I think that's why I decided to stick with psychiatry, because you get to connect with patients on a deeper level. And I spend so much time with them talking about their families or their mom that passed away, or their kid that drowned, or the kid that shot himself. Or, I mean, you hear some stories, but you don't know how much these people like appreciate you just listening, just being there to listen to their stories and understand them, and showing empathy and compassion for them, and just letting them speak. You don't even have to say something most of the time. It's just so relieving. And I really take joy in that. I mean, of course, as a person, I try not to bring that home with me. Of course, try to separate myself from that. So when I come home, I decompress. Sometimes I go to therapy myself. Being in psychiatry, I have to talk. Sometimes I hear a lot of stories that bother me, like kids being abused or sexual abuse, sex trafficking, all the things. But at the end of the day, I don't think I would change it for anything in the world, just because of the impact I get to make and the people's lives I get to touch by doing this. So I do enjoy what I get to do. And I think it's a part of work-life balance too, because since I work outpatient, no weekends, no holidays, no call. So Monday through Friday, 8 to 5, that's it. I'm not made for 12 hours. Kudos to those who are.
Okay, Rashada, let's talk about that. So in your job lineup, you do not take call. Is that right?
No, I don't take call. If I ever have a moment where we take call, like my SP will tell me ahead of time, this person will be out. You may or may not get a couple of calls from their patient, but just in case, this is the on-call phone. We do have an on-call phone, but very rarely do I have to take call. We normally like to try to get ahead of it. So if we know we have like a complicated, complex case, we will see them every day until we get them stabilized. That helps for the psyche because they like the attention, but that also helps to get them stabilized so you can keep up what's going on with them every single day. We will see them every day.
What I was trying to get to was sort of the difference between a physician-controlled practice versus one that has advanced practice providers like yourself. And so that you are able to fairly well structure your on-call situation so that you don't have to be on call given what you're doing.
Right. And if I do, it's very, very seldom.
Yeah, and I would point out that you currently are having about 300 kids listening to you online, probably 2/3 of which are very interested in becoming PAs. And so they're very interested in hearing more about how you set up what you set up. Now, Rashada, nursing practitioners, NPs, have to do specific training in the areas, whether it's emergency medicine or so forth. A PA does not. Is that correct?
Right.
So would you talk about that, please?
Yeah, because from what I understand, and I may be right or wrong, but the NP track, they have to actually pick a track or pick a specialty or a path they're going to take and then hone in on that. Whereas PAs are trained across the board, we get the basics. And then when we graduate and pass our boards, of course, and all that good stuff, you're supposed to get a job that will foster your growth. So now you have the knowledge, at least the basics of everything. And then you're supposed to hone in and go more in depth. So like psychiatry, for instance, I didn't do a fellowship, and that would be like, like a residency for doctors. I didn't have to do a fellowship. It's not required for us because we do get that basic knowledge across all ends. But I will definitely say it wasn't hard. Like going into graduating and going straight into psychiatry, I knew, long as I knew my drug classes and what they do, and based on the symptoms I heard, I knew how to treat it. And that's how I operated for a long time until I became comfortable. I did call my SP a couple of times, and I could have had some more complicated cases like epilepsy and bipolar disorder with atypicals and all that stuff, but it wasn't that bad. And I don't know if that's because I have a passion for it or what, but it wasn't terrible. Like I felt like I was well equipped from what I learned in school and how I was taught to go straight into the workforce. And with the fostering and the care that, they taught me how to use the EMR and all that stuff, but my SP was wonderful. And I wish everybody has a supervising physician like him. It didn't matter what time, what day, if he was in clinic running his own, talking to a patient, he would answer my call, my text message. Right. I had a question.
So Rashada, you've been out how long? When did you finish school?
I finished school in 2018 and I started working May of 2019.
Okay, so you're 3 years out.
Almost 3, yeah.
So how's it going? Are you happy doing what you're doing so far? So good?
Yeah, so far so good.
Well, explain, why are you happy about it? I mean, there's so many people dropping out of medicine, and why do you like doing what you're doing?
Because I feel like I make the biggest impact in psychiatry. I feel like this is an area where we have so much stigma that people are reluctant to come in to even seek help. So when they finally get the muster up the faith to come in and actually get help, I don't try to back them into the corner. I don't try to force medications on them, but rather I take a different approach. Like I listen to them, I gather all my information, and I say, okay, is there anything else I didn't ask you about that is of concern for today? And I say, okay, breathe. Are you okay? Is it, I check in with them. I try to be very personable. And then I say, all right, so based on everything you've told me, this is what I think we're dealing with. I could be right. I could be wrong. But based off of, remember, you told me this, and this, I always tie it back into what you told me, just so you don't think I'm throwing a label on you. But I say, I could care less about the labels. We're trying to treat your symptoms so you can feel better, so you can get sleep at night, so that you can operate, so you can function. And so this is the medication I feel like will cover all of that. And you don't have to be on 6 different medicines. We're only going to start one at a time. And these are 2 options you choose. These are 2 options, the good, bad, and the ugly you choose. And that's pretty much how I get a chance to make an impact. But people are so happy that it's not what they thought it would be and that they learned so much, because I try to set patients up for success. So if they decide to move out the country or go to another provider, they can advocate for themselves because they know when their moods are not stable, or they know when their medicine isn't working, and they know what's going on and they understand the disorder. So
Rashada, there's an old phrase in medicine that people go into psychiatry because they're crazy themselves and they want to understand themselves better. So are you crazy? Or are you understanding yourself better, or what?
Oh, Lord, I think we're all crazy to some extent, but yeah, I do. I think I'm off my rocker. I lost it a long time ago. I really do. I lost it.
What do you think about all this stuff of burnout in medicine and all the people that are leaving medicine at the same time that you've just started? What in the world is going on, Rashada?
Oh, I understand. I mean, with COVID and how especially the hospitals and how they were overran and people from other specialties went in to help, and it was just crazy. And then today, the foolishness we see today, and that's another topic, but then especially in mental health, I mean, everybody, it's like a wave of people are now seeking psychiatric mental health and things. And the burnout is real. I actually had a colleague actually turn in her resignation not too long ago because it started out like She just looked tired. And then she would come into work and do it. And at lunchtime, she would say, I'm going home for the rest of the day. I'm not feeling well. And then she just finally said, guys, this is too much. Like, I'm just burned out. Like the amount of time we spend with patients and the effort, like even when you don't want to on a normal day in any specialty, you have to put a smile on your face and interact with the patient. In psychiatry, it's like 10 times, it's so draining, like the type of energy you have to put in. And so I feel like a lot of people, like burnout is nothing to play with. I do feel like it's real, and trying to find that balance right now is particularly hard because we don't have a lot of people that do psych. So
Rashada, do you think that, I mean, I've been practicing 44 years and you're fairly well just getting started, but do you think that allowing ourselves connect with our patients on a somewhat personal level, but I mean, certainly interpersonal level,
yes,
helps prevent burnout? Do you think? I do. What do you think?
I definitely do, because then not only do you understand your patient more, but then they understand you more. And I know, like, the patient isn't supposed to be thinking about you. You're supposed to be thinking about the patient, but sometimes like the patients will get it. Like y'all have that rapport already built, and it's just kind of like, yeah. And like, they will tell you if something's wrong. But other than that, I mean, if medications are working and other things, it's just like we catch up and like, all right, see you later type of thing. But yeah, I do think that helps. If you don't, then it's kind of.
Rashada, do you think it's possible that we can get too close to our patients emotionally?
I do. And that's why I was like, you can't bring that home, and you can't cross those ethical lines. So no counter transference and all that stuff. And yeah, I did that too, and blah, blah, blah. But you just make sure that the patient is talking about them, and it's about them the whole time, because they're coming to see you for help. And you don't want to be talking about yourself in the session with them. They're the patient.
Yeah. Who's the one giving therapy here? Yeah, right.
Yes.
Well, please go on. I'm sorry to interrupt. Your story is so wonderful. Keep going, please.
No. Okay. So GRE for Dummies, awesome. I used Kaplan when I took the GRE the first time, hated it. I have ADD myself, and I don't like standardized tests. So the Kaplan book was like this thick, and the print was like this small, and everything was like exactly how you would see it on the test, but I don't learn that way. So I needed somebody to like really refresh my memory of all the high school math and all the other stuff that I learned. So GRE for Dummies did just that. It broke it all the way down as if you were explaining it to an illiterate person, like a dummy. But that helped me because it made it very simple. So I was like, yeah, I can get this. So for me, I put all my eggs in one basket, and I went after the math, because I know if you do this, this, and this, you'll end up with the answer. English was kind of like, what word means this? I can probably guess what the suffix or prefix means, or what the root word means. But to me, it was just too like abstract, which is ironic. But I was like, no, I'll put my most focus on math, and that was my highest score for the GRE. So I definitely say I took the GRE twice, because the first time I was short a couple of points because my school didn't accept writing. So just make sure you read that you go to your school's website and read that, because you'll know like if you need to really put effort into the writing or not. If your school don't accept it, then it really doesn't matter. And there are some schools that don't do or require GRE, or have waived the GRE requirement since COVID. So make sure you also are up to date on that. And if you're unsure, please call. That's why they put the phone number to admissions on the website. Please call. Never be afraid to call. Okay, so this was baby Rashada. So this was Rashada back when I passed my CNA exam. So I started off as a CNA. I started off at the bottom of the food chain. I had just passed. I was so happy that day. I did that for patient care hours, and I worked in the nursing home, and I did at-home care. So when I worked in the nursing home, of course, they're short-staffed, and I would have 2 halls at a time, and patients I had to get up, feed, wash, bathe, put back to bed. But I mean, like all the things, and I had no help.
Rashada, that's the most beautiful picture I ever saw in my life. That's a wonderful picture. Good for you.
you. Thank you. I think
and it's not the bottom of the rung. It's it is the most inferior rung on the ladder of whatever. Okay.
Yes. We work hard. We work real hard.
That's a great picture.
Thank you.
Anyway, I'm sorry. I just had to love that little bit for me.
Thank you. No, you're fine. And so I did that. I worked for Home Instead. Home Instead, I'm pretty sure some of you probably heard of Home Instead Senior Care.
No, what is that? What is that?
It is a corporation or a company that was founded out of Charleston, South Carolina, actually, by this guy and this woman. Their parents were elderly and sick, and they started the company off of that and wanted to base for companionship.
Home health, is that what it was?
Yes, home health. For companionship, you don't have to be a CNA to work for them. You could just like do companion work, just keep them company. But either way, they were a very great company to work for. They paid you for all of your time. And it was very rewarding. I worked with specifically dementia, Lou Gehrig's disease. I had 2 patients at once with them, and I even did a couple of overnight shifts. But I did that while I was in college. So this was, of course, during summer that I would do those types of shifts. And then on the weekends, I would do the nursing home. So,
Rashada, that's the way of the future, without any doubt, is home health care, folks being able to be on home hospice and so forth. Even medical admissions to hospitals, actually being discharged to home, is the absolute way of the future. And so the home health care provider of the future, I don't know that we exactly know what the qualifications are going to be for that person, especially if we say, the person's not quite sick enough to be in the hospital, so they're going to be at home hospital with an IV, with antibiotics and so forth. Who will that person be? And I think that we don't know right now. But anyway, thank you for that service. Taylor Sanders, whom you met earlier, introduced me to Atul Gawande's wonderful book, Being Mortal, which is all about understanding more about, how we take care of people who have enormously complicated problems at home. So anyway, please go on. I'm sorry to interrupt.
Oh, I just want to write down that title.
Atul Gawande, Being Mortal. I will email it to you. Ali, help me remember, and I'll email the book to you. I'll send you a copy. It's a very important read. I just finished it. Very life-changing read. I would encourage all of the students to read Being Mortal by Atul Gawande. Very important book. Keep going, please, Rashada. Yes. Sorry.
Okay, no, you're fine. So that's what I did for patient care hours. And I basically use my pay stubs. On your pay stubs, they have your hours, and I used that to help me tally up my hours. And it was electronic, so I could get in the system and pull it up. And that's how I entered it on CASPA. And then shadowing hours. So I had 1 doctor and 2 PAs. So the doctor I shadowed was actually my professor at Coastal Carolina. He taught anthropology. And if I pronounce that right, sometimes I get tongue tied, but he was awesome. I was talking to him about going to PA school, and he was like, well, I'm a doctor. I was like, really? And he was like, So he was like, I can contact HR and we can get you in. And that's what he did. And when I shadowed with him, it was in the ER. And I had my first testicular torsion, which was painful to watch. The guy came in screaming with him. And then I saw my first death, and I had to process that. But that was interesting with the doctor. And then he had a couple of PAs under him, and they would come and get me sometimes, and they would let me do little things like hold a fingernail on while they sutured it back on, or do little things. But of course I couldn't do anything yet, but it was fun. And then 2 PAs, so they were at 2 different hospitals apart, aside from that hospital that I was shadowing at, and it was all ER. I've seen anaphylaxis come through. We had codes, all sorts of things. And I thought at the time, like, I switched from cardiology, and then from doing all this shadowing in the ER, I was like, I'm going to work in the ER. I'm going to save lives, and I'm going to give back to my community. And I was so passionate about it. And I was like, I'm going to do ER work. And then after I saw my first death, I was like, I said the day where I get used to seeing people die and it don't affect me is the day I don't want to practice medicine no more. And I was so serious about it, I was like, I don't want to do ER. And so that kind of turned me off to ER. That should show you right there. My heart was too big and I'm too emotional. And so I was like, I can't do that.
It's, Rashada, it's a tough job. We watch people come in, they're breathing and they're in some state of wellness, and they come in and something terrible happens and they check out right in front of us. And how do we handle that? And it's hard, especially if you really, really like people. It's very hard. It's tough. Yeah. It's an emotional injury. What do they call it? Moral injury for all of us.
Yes.
Please keep on. Please.
Yeah. So I said no ER for me. And so I had to figure out what else. I went back to cardiology after that. I guess this was before I got to PA school. And then once I got into PA school, so my struggles as a student. So I don't know about you guys, but I didn't realize how type A I was until I got into PA school. I denied being type A forever. It's like, I'm not a type A person. Even though I was an honor student and all this, I was like, I'm not type A, I'm type B. I'm very laid back. I'm this, I'm that. No, I'm type A to the T. And PA school brought that out to me. Stress, because I am type A, because I want to get everything right, because I wanted to get an A on everything. If you come into PA school with that attitude, it's possible you can achieve it. But what is it going to cost you? You're learning so much information. Sometimes you don't know what you know and what you don't know until you take the test. Like, it's a lot. So stress and time management is probably my number one, because I would always be stressing. I would have like 3 exams in a week or something. And I'm like, okay, death by PowerPoint. We have over like 6 PowerPoints with over 2,000 slides. And the teachers will always say, do not get caught up in the weeds, especially with cardiology, because that was the longest and hardest block ever. They were like, don't get caught up in the weeds. Don't get caught up in the weeds. But it wasn't until I was close to graduation that I finally understood that the test is going to have a scenario about a patient, their presentation. Either they're going to give a diagnosis, or they're going to ask you or tell you the diagnosis, and they're going to ask, what do you treat it with? Or either they're going to say, what would your imaging be? Or what would your rule out? What tests would you order? And so after I got that in my head, and I'm like, oh, I don't need to know what year it was founded or who founded it or who it's named after or what continent, this, that. I need to focus on patient presentation, my what I'm going to order, imaging, what my findings, and then how I'm going to treat it. And once I got that down, then that cut out a lot of the time I was using studying nothing and worrying about nothing. But that was my number one. And then second, understanding how I learned and my study style. I didn't figure out that I was an auditory and visual learner. Well, I knew I was a visual learner, but I didn't know I was an auditory learner. So a podcast became my way of understanding everything. That, osmosis, Kaplan, MedCram on YouTube became everything for me, because that's how I studied. And sometimes the teacher would explain it and that wasn't enough. So I started recording lectures, and I would be driving to rotation and listening to a lecture or something, and I would hear like 15 other extra things out of a 2-hour lecture that I didn't hear. And I sit on the front row. So I was like, how did I miss that? So learning my study style, I'm like, okay, I'm an auditory and visual learner. And then comparison, because you are type A, you might be, it's very easy to get hooked up in cliques and all that in medical school or PA school, and to be like, yeah, this is my friend. And it's supposed to be everybody's helping each other pass because y'all are all going through the same thing. But sometimes it becomes competition. And that's a very toxic thing to do, but sometimes it just happens. And so like, you'll compare yourself. You gave it your all. You studied, but for some reason you just didn't do as well on the test as you thought you did. And then you hear somebody else bragging about making a 90, and then you beat yourself up. So those were my struggles as a student, and I would advise against that wholeheartedly, but that was my struggle. That was my struggle. Some important things I would say that you need to know before PA school. You need to know your why. So I hone this in on my mentees. I do mentorship, and I always tell my mentees, this part of your application to PA school is the only part of your application that is different from everybody else's. Everybody has good grades. Everybody has a decent GPA for the most part. Everybody probably has stellar recommendations. What sets you apart from everybody else? Your volunteer hours, what you do for the community outside of school, but your why is supposed to pull at the heartstrings. This is not a place where you say why they should accept you, or what experience you have, or your dad is a doctor, or your whole family is a doctor. This is the part where you say, at 14, I saw my first cousin got shot by a gun wound, da, 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 da. I mean, it's something that you have to put your own personality into, and it has to be heartfelt. I feel like if the admissions committee is supposed to read your personal statement from everything else that they saw in your application, that is supposed to be like, yeah, I think I want to get to know this person. I want to see them. It makes you jump off the page.
Yeah. So Rashada, are you saying that you have over 300 kids listening to you right now. Are you saying that these 300 kids have to be able to sit down and write down in a convincing manner about why they want to get into medicine? They have to write something that really explains why they want to do that?
Yeah, your personal statement.
Is that level of maturity required?
Oh yeah, because if you can't, then maybe you have to second guess why you're doing this in the first place. I'm
teasing you a little bit, but I mean, explain what you mean.
So that's what the admissions committee wants to see. They don't want people that just want to be in medicine for the money, or they're not going to do an impact or good works for the community or patients. They want to know that they're letting people into medicine that are going to do good works for not only the community, but for their patients, and they're going to treat them right. And they have a why behind it. They're just not, I'm pretty sure everybody has experienced the lazy nurse or poor care or something like that. You don't want people like that working in medicine. We want people that really want to be there. I mean, yeah, you want people that really want to be there. You got to know your why, because if you don't know your why.
So Rashada, do you really have a personal and professional interest in your patients? Do you really care?
Oh yeah, I care. I definitely do.
Explain that to me, and I'll do the same. Explain that to me.
So, well, I don't want to use that example, but I can.
So use any example, whatever.
Okay. So like if I deal with a lot of suicidal patients from 5 and up, don't matter. I see patients of all different ages that are suicidal. If my patient were to kill themselves or do something, that would just crush me. But I know ultimately it's not my fault, or there's not anything that I can do. I mean, if somebody's going to do it, they're going to do it. But of course, if I can save a life in that capacity, if I can say something that changes for 1 second the way they think about suicide, or the way they think about their life, or the way they think about their current situation, or give them a glimpse of hope that it can get better, or I am listening, or there is a medicine out there that's going to work, or they're not worthless, that means everything. I mean, I really do think making that impact and that connection is everything to me. So I am passionate.
You listed like half a dozen opportunities for treatment just then, which I thought was very interesting. Rashada, for me, it's, I'll be 70 this year. I've been practicing 44 years. I'm a single guy. I have no kids, but my next older brother has 15 grandchildren, but the most social thing I do, Rashada, is the practice of medicine. And I love talking to patients. I really enjoy it. Sit down, hold their hand, talk to them, and just find out what's going on with them. And oh, by the way, are they safe at home? Who's taking care of them at home? Where do they live? Are they homeless? And so on. So you can have an opportunity to be involved in the lives of others. And the relevance of that is enormous. That's what I think. What do you think?
I agree. It's no better feeling, really. It is.
I wasn't trying to talk you into that, but hey.
You got me.
Please, I'm sorry to interrupt. Please keep talking. You're doing a wonderful job.
Thanks. I would just say know your why, because when you write down your personal statement and on your hard days when you feel like you want to give up and you need a reminder, I made copies of my personal statement and I had it in every backpack bag. I had it posted in my room so that when I felt like I wanted to give up, I would say, you have to keep going for your patients who need you, for your future patients who need you. You have to keep going. When you do medicine, it's never about you. It's always about your patients. It's always about who you're serving. You're a permanent servant and a lifelong learner forever. So when you actually know your why, that is your motivation for finishing. So you have to know that. And if you're going into PA school, particularly, know the versatility of the profession. There are so many people that I've met, and I know it's easy to get caught up on social media and you go with the wave and what's hot and the bandwagon and everything, but please actually do research and know what a PA is and what we can do and what we can't do. And I know that varies across state lines, but please know that we can switch specialties. We can do this, we can do that, even radiology, we can do. So just please do some research. Know how you handle stress, because I've spoken to a lot of my mentees that got into PA school, and they always more than likely say that's one of the questions they ask in the interview. How do you handle stress? What do you do for fun? What are your hobbies? Because they know PA school can get pretty stressful. And then just know, of course, the profession and the scope of practice, where you stand in the profession, but also your scope of practice, which you probably really won't know until you start working, but like at least a generalized idea, some type as you get close to rotations and graduation, just at least know before you go into PA school. Okay, I actually put in for questions. So do anybody has any questions at this time?
We have like 100 already.
We have a good amount.
Students have been hammering us with questions about, Rashada, would you change your mind? Would you go back to med school or nursing school, or are you doing exactly what you want to do?
I'm doing exactly what I want to do. When I went back for my doctorate, and that was only 12 months, and I was like, why am I doing this? Why did I do this? Like, I don't think I'm not going back to school. I'm done.
Let me understand. You've gone back for a PhD, correct?
Yeah, it's my DMSC. It's the Doctorate of Medical Science from Lynchburg University. I went back for 12 months and I learned about global health and the legal aspects of being a PA and the business side of running your own practice, which I can't do in Texas, but I learned about it and other things. I think it was valuable.
What made you make the decision to get that additional degree?
I want to sit at the table. I think besides that and teaching, I think those are the only two things. Teaching, I enjoy, as you can see, I enjoy talking and explaining things. But if I ever want to sit on like TAPA, the Texas Association of Physician Assistants, I could. I just feel like it would give me some leverage and it would possibly catapult me or be a catalyst into holding a leadership position or something like that. So I just went back and went for it. And I was like, it's 12 months. How bad could it be? But then it about stressed me out when I went back because I was right back on that hamster wheel. And now that I've graduated, I was like, never again. I'm not going back to school. I'm done.
So, Rashada, what has been the most life-informing thing that's happened to you in the last 3 or 4 years? You finished school, you've gone back for an advanced degree. What has been the most informing thing that if you were going to, you've got 314 kids listening to you right now. If you were going to say, this is the most important thing that has been revealed to me in my training and in my early clinical experience, what would you say to these students?
As it pertains to psychiatry or just in general?
Your choice.
I would say in general, don't treat the number, treat the patient. There could be like something going on and the numbers or the tests that you order don't reflect that, but the patient looks sick, they're running a fever, you treat the patient, don't treat the number. I think that stuck with me from PA school. And one of the things that you never want to miss is a PE. That just haunts me to this day, because while I was in PA school, ironically enough, my best friend died from a PE. So I don't think I would ever try and miss a PE, and knowing the signs of that. But I would say psychiatry wise, I would just say, whether you know it or not, and you're watching like someone's nonverbal communication, your nonverbal communication is being communicated too. So just making sure that you're watching, you're mindful of yourself as much as you're mindful as the patient when you're in psychiatry. And also always never take for granted that the patient is telling you the truth. I have found more liars, more fabrication, more like, just always take it with a grain of salt and do your own research. That's why I said collaborative background, as much as you can, much information as you can from patients, and make sure you always do a UDS, because my Lord, but yeah, yes.
You're in drug screen for the students.
Yes.
Well, in about 3 sentences, you said so much. Firstly, you talked about, as a PA broadly, as a provider broadly, pay attention to vital signs. My medical students and my residents all know Fowler's first law, always explain a tachycardia. If a patient is having a tachycardia, there is something wrong with them. And until you've explained it, don't let them out of your sight. Right. And then, gosh, you said such wonderful things about psychiatry, which is, you said patients lie. There was an interesting article that was in JAMA a couple of years ago, which was, that when you ask a patient how much they drink, I drink 2 beers a day. And they got, the study was actually about getting collateral information from families. And they would ask the family, well, he says he drinks 2 beers a day. You go, oh, no. Oh, no. We throw away the beer cans and the bottles. Oh, no. No, it's 5 times that much. And they found that patients actually drink, they actually admit to about 40% of how much they actually drink, which is about 1/3, which is times 3, which is whatever they tell you, it's times 3.
That is true.
I'm sorry. This is your question and answer. Please, Ali, get me out of here and talk to.
Right. We're just gonna ask a couple of questions that the chat has been asking. So this one came pretty recently, and I feel like it's a very important question for you to answer, because a lot of people are going to start applying, they're going to start writing their personal statements, and someone asks, how do we explain the why medicine, or why PA, or why this, if we really never had that life-changing experience? Yeah.
So that's kind of hard, because then I'm asking, well, why are you applying? Like, why are you interested for PA school? Are you just applying because it's something that you feel like you should do, that you might be interested? I mean, because you're going to be learning a lot, and you have to go through a lot. There's a lot of money involved. It's a lot of everything involved. So for you to, you might not have had a cousin shot in front of you, or maybe an immediate family die from something, or maybe an illness yourself, but I'm sure you can think of at least one thing that's encouraging you to apply, I would hope.
Right. It's more of you trying to you got to find out why. It's not that, the world hasn't might not ended in front of you, but there's a reason why you're applying. So it's up to you to find out why. That's kind of what you're saying.
Yeah.
All right. So I hope a lot of y'all keep that in mind. The next question is, since we're talking a little bit about mental health, how do you feel about the stigma surrounding healthcare workers with mental health issues?
I feel like it's the whole stigma thing in general is terrible, because you're pushing people away from seeking help and actually getting help because they think it's taboo. And I mean, you're right. Back in those days, in that era, nobody talked about it. And I've since seeing patients in Texas, I've learned the phrase, you don't talk about your crazy. So you don't talk about your crazy, you don't share your crazy. I've heard plenty of patients come in and tell me that was born and raised here in Texas. And that seems to be the thing that they were told when they were younger, because their parents just, I mean, I feel like it takes a lot more strength to pretend like you're okay and try to deal with your mind on your own rather than take medicine to help you. I don't know. I'm like kind of conflicted, but I think as when it comes to healthcare providers, I think they're the best ones, because especially if they're medicated, they have it under control. There should be no discrimination against people and their needs. Like me, myself, I'm ADD and I have anxiety and I'm in health, like I do psychiatry. I feel like we're the best ones to understand what the other patient is going through. And we're more able to pick up and sense it. And I feel like to a sense you attract those patients because that's you. Especially you're the patient who has the anxiety, and you understand more from where they're coming from. Of course, like I said earlier, no countertransference and no like getting to crossing those ethical guidelines, but you make it more easier for you to express your empathy and compassion to the patient in a professional way. I feel like we're the best ones, the people who do have mental health disorders. Yeah, and I think to an extent, everybody has anxiety at some point. So
Ali, give us one more quick one, and then we'll go to the second half.
Oh yeah, definitely. So I know you talked previously about, you want to be having a seat at the table and, trying to elevate other minority voices in medicine. So what advice would you give to fellow minorities in pursuing a career in the medical field?
I would definitely say keep your head up and know why you're doing it, but also when it gets hard or when things don't happen right away or when things don't turn out the way you want it to, that doesn't give you a reason to quit. Because if that's all it takes for you to give up, then maybe we should reconsider here. Like you got to have tough skin, thick skin. Not to go down a rabbit hole, but I mean, being a provider of color, I have experienced some unfair things, especially from some of my patients. I've had patients make comments and you just have to smile and say, you know what, that's your right. Thank you very much for coming in to see me today. Yes, please have a great day. You still have to remain professional, of course.
Right.
But sometimes that can be hard for a lot of people because it is unfair and you want to react, but you got to have that self-restraint. So I would definitely say keep going no matter what door is closed in your face, and know your why, but also have tough skin and make sure you're not a person that just reacts to things, that you can respond to things and take things, because there are going to be things thrown your way. And sometimes, majority of the time, you will be the only one in the room, but you got to know how to carry yourself professionally.
So Rashada, are you saying that any candidate for a professional position is going to have some kind of toughness of some sort?
I really do.
That is not just going to come easily, but that you have to be tough about things.
Yeah, I mean, even when I was on rotations, I felt like some of the doctors I shadowed or PAs that I shadowed didn't like me initially. But I mean, you only have those 6 weeks. And when you get in there, it's like halfway through, you're just now getting used to being there. And then at the end, you feel like, oh, I could work here. I know what I'm doing. I know the staff, and then it's time to go. But not to take it personally, like they can pimp you. They can say something that maybe you took offensive. And nowadays, everybody is easily offended, but you just got to have tough skin and again, carry yourself professionally. I mean, you can't let everything get to you. I think that goes for all of medicine, really. Residency, rotations, don't matter. Yeah.
Rashada, I think the hardest thing for me was, I remember when I was really young, many years ago, almost 50 years ago, that I didn't remember patient information very well.
Yeah.
I just didn't remember it very well, patient to patient. Today, for some reason, my mind records it as I walk in the room like a video recorder.
Yes.
But when I was young, I didn't do that. And I remember that it took me a long time to be able to begin to, record patient information so I could begin to sort through it. So Have you had any similar, um, what am I trying to say? Not shortcomings is the word, but, blockades along the way that you've had to jump through things in your own life?
Oh, yeah, really. Like when I first started in psychiatry, I would say learning what medicine interacts with others, but I've learned to use tools for that. But then also what age you have to be on what medicine. That's so crucial. And I made that mistake one time, but once you make that mistake, you don't make it again. I gave a 17-year-old a medicine that she was supposed to be 18 to take. God, thank you, she wasn't younger, because she responded really well. But when COVID happened and she couldn't get the samples from the office and she had to go off the medicine, she entered into a depressive episode, lost weight, wouldn't get up off the couch. And the parents actually ended up spending money out of their 401k to cover the cost of the medicine. It was a hot mess because it was off-label. It was considered off-label use. And I never made that mistake again. So now I double check, triple check that. And also just learning the EMR system. That was something I messed up a lot. I made a lot of mistakes.
Well, Rashada, we've been talking almost an hour and we are thoroughly enjoying this. And
Yes.
We're only about halfway through. You need to get a sip of water or anything? Or are you doing okay?
Oh, no, I'm good. I got water right here. I'm good.
I gotta use some water. I need to break my fast.
We are. Ali is going to get some water. Well, Rashada, this is wonderful. We're thoroughly enjoying this. And please just take it away and cover whatever you want.
Okay. So a day in the life. So, I mean, this was me. I'm in my old office in Virginia, but I still work the same hours, still 8 hours a day, but now I just work from 7:30 to 4:30. I'm in an outpatient clinic setting. I see ages 5 and up. And at the very bottom, I had group home and foster care because I worked very closely with social workers and foster parents and so forth, group homes and DJJ and all that in Virginia. But I changed it to patient education because now I spend most of my time with parents. Parents seem to be the thing. So I spend most of my time with parents, educating them on the disorder. And most of the time, if I help them see the picture from whence they came, and then now they can make the connection. Oh yeah, they remind me of my mom, or oh yeah, they remind me of my dad. So I spend a lot of time doing patient education, even if it's not with a minor, just a lot of time explaining things. If you are interested in psychiatry, I would definitely say, I get this question a lot. People confuse psychiatry and psychology, not the same. Psychology definitely is like the peanut butter to the jelly. Like we go very well together. They study behavior patterns and theories and all these things, personality disorders and all these other things that kind of overlap with what we learn. But psychiatry is the medicine side and psychology is like the other side. Like we work very great together. I don't know how to explain it, but I work hand in hand with the psychologist now. And she is a forensic psychologist and she does a lot of testing and she does batteries of testings. And when I get in a funk or if I get stuck, she's able to come right through and put things in a way that people are just like, oh, like she make it very understandable and relatable. I don't know how she does that, but she's awesome at what she does. So we're not the same, know the difference, but we work very well together. We do not do therapy. So CBC, CBT, DBT, EMDR, habit reversal therapy, all that stuff, we do not do therapy. We do supportive therapy. We counsel the patient on taking their medication and adherence and all the things, but we don't do therapy. Of course, you could do both if you want to go to school for both and then finish and then do it, but we don't do it usually. Compassion, empathy. I talked about that a little bit earlier, just making sure you show compassion and empathy, not sympathy. Don't try to separate it. Try to go to therapy, take care of yourself, take care of your own mental health, self-care. Non-judgment. So it's very easy to judge a lot of people when you don't understand. So when I worked at a place that had an IOP for substance abuse, and there was a lady in the office that didn't particularly like substance abusers and thought very opposite of them and less of them. And I was like, no, when you're in psychiatry, you can't be judgmental because believe it or not, the patients can pick up on that. And if they don't feel comfortable with you, they're not going to open up to you. And that's everything. As we've already talked about, that's pretty much all of your information you get to make the diagnosis, the conclusion you come to, what medicine you're going to use. You need their information. So please don't be judgmental. And just know in psychiatry, you're part of an interdisciplinary team. You want their primary care, their cardiologist, their endocrinologist, all of that overlaps. So you want a release of information for all of those because there is a lot of psychiatric medications that affects plenty of different parts of medicine. So make sure you don't step on anybody's toes and you're communicating as much as possible and you're listening. And last but not least, you learn to say no. When I first started in psychiatry, I hated to say no. I thought I had to, be a patient pleaser. Not in psychiatry. People will come in wanting Xanax and Klonopins and all the things, and they don't need it. They're drug seeking, and not everybody's a drug seeker. And I believe what they say they're feeling is real, but it's for you to read in between the lines of what they're saying, and then for you to explain. Yes, you are anxious, but this is why you're anxious. You have a mood disorder, or this isn't anxiety, that was mania, or this isn't, then this is why. And then they're like, oh, okay. So no, you can't get Xanax, but we can talk about Abilify and Latuda and everything else. So just knowing how to say no. I think we already talked about that. Case study. Okay. So in my case study, my little made up case study, I have a 33-year-old female that presents to the office with complaints of paranoia. She reports that she believes that there are, it's not letting me see what's under this. That there are cameras in her shower that watch her in the evenings. And the patient states she has even heard a bird at her window in the night calling her name. Patient states when she goes to the supermarket, she feels the employees are broadcasting her thoughts to everyone else in the store. And she feels isolated and withdrawn at times. She is depressed at times and will emotionally shut down. She has moments of disorganized speech, or she say things that makes no sense, and her friends have pointed it out. She does admit her mother has had similar symptoms, and her symptoms started when she was in undergrad, so probably like around 20-ish or 18 to 20-ish. Patient states she had to drop out because she was hearing voices. She was having hallucinations during the lectures, and her paranoia has caused her to lose relationships and employment. And she nowadays, she just hears them consistently during the day and she wants them to stop. So what does she have and how would we help her? So she gave us a lot of information, but then here comes the objectives. So when you look at her, she's unkempt, she's disheveled, she's malnourished, she's alert and oriented, and she speaks linear. She has normal rate and tone. Concentration is fair. Judgment is poor. That's just a little snippet, but there's more. There's more questions. But just from that little bit of information in the case study, can you guys guess the diagnosis? And you can put it in the chat. I don't know if we...
Yeah, they're putting it in the chat.
Yeah, Rashada, I'll start. This could be psychotic depression of someone who's just degenerating because of severe depression from personal issues.
Right.
You got a lot of schizophrenia coming in.
Yeah,
the chat
everyone's
there.
spamming schizophrenia.
Yeah, maybe I made it too easy.
Yeah.
Well, perhaps, but maybe not. Go ahead.
Maybe not. Yeah. So
No,
yeah, it is. It is. And I mean, even more because I mean, we have a seasoned veteran on here, so Dr. Fowler. But I mean, yeah, it's for the sense of, you know, sympathies. I don't even know what I'm saying. I'm half tired, y'all. But to be simple, schizophrenia. So she has delusions. She has disorganized speech, thoughts. She has hallucinations. She has the ideas of reference. So if we go back to feeling like when she goes to the supermarket, employees are broadcasting her thoughts to everyone. And it's kind of like she's on this roller coaster of going down. We're depressed, we're okay. For people like that in schizophrenia, I call it the washer machine cycle. It's prodromal phase where everything might be okay, but right at the brink of it, they start entering into depression. And then the active phase where they have all the hallucinations. And then the residual, probably when things start to calm down or go away, and then they're okay for a little while, and then it restarts all over again. And what was important about it was her onset, but also her family history. She didn't say, yeah, my mother was diagnosed with schizophrenia, because remember, that probably wasn't something that was diagnosed, talked about, or treated. But she said, yeah, sometimes I like to ask patients, well, if you could think of somebody in your family that you think your symptoms or the problems you're having kind of remind you of, who would it be? And sometimes they're like, my dad or my mom or my grandma had the same issues I'm having. And that kind of tells me a lot of information just by that. But then also the onset. So schizophrenia usually early 20s is the onset. But I have seen kids, I don't know what it is, but I don't know if it's the times we're in or what, but I have seen kids come in and they're psychotic. They're literally psychotic. What they're telling me, they're having delusions, and we have to get them stabilized, but they also have a very strong history of it. And so, yeah, I've seen younger and younger. It has amazes me how young I've been seeing early onset schizophrenia, but also the downward spiral. So a lot of our homeless population suffers from schizophrenia because of the stigma and their lack of knowledge about the disease or what's going on. And with every psychotic episode, the brain matter gets smaller. It shrinks, it gets smaller and smaller. Their executive function goes down. They're not able to keep a job. And that's how most people do end up schizophrenic. They're not able to take care of themselves and take care of things like paying bills and responsibilities, and they end up in the shelter. And sometimes I have seen a lot of the homeless population talking to themselves, walking down the street, or having weird, erratic behavior. And you feel so bad when you see that, but there's literally nothing I could do. Like, I can't go around here,
So Rashada, just in the last two sentences, you talked about all of these things surrounding the patients, their living situation, their ability to write checks and so forth. Are you saying that in medicine that we have to deal with all of these activities of daily living to be able to support our patients?
I actually, at my last job, we did actually hire care coordinators just for that. So we would have a whole list of community resources. And at times we would literally have the patient sitting in the office because they were in our substance abuse program. And we took a lot of Medicaid and Medicare. So we would try to help them find housing or find a social worker or a care coordinator or somebody in the community that would help them reach their goals or put them into a shelter or help them find housing. So yeah, it's like,
the reason I bring that up is that, hell, I'm a professor in a medical school and I've been doing this for over 40 years. And I spend so much of my time making sure that Aunt Minnie doesn't fall when she goes home.
Right.
Because if she falls and breaks her hip, she will die.
Yes.
And so what you're saying is that in your world, you have to be very involved with all of these personal things about patients' ability to conduct their lives.
Yes, it's so multidimensional. Like, it's just, yes, it is. Yes, I do.
Yes, I know, but I just wanted you to say that. So please keep going. Downward spiral. It's funny. It's interesting that 33-year-old, that's kind of a medium age for a schizophrenic to emerge.
Yeah.
I had an accountant many years ago that in his late 30s, it turned out he had an episode, and then in his nearly 40s, he lost his mind and never recovered. And so it's interesting, this thing called schizophrenia.
Yeah, and how it never comes back. When I went on rotation, one of the patients, she came in and they were like, "Oh, you'll like this one." And I was like, "Huh?" And they were like, "See, ask her questions." They let me lead it. And everything she said, she was like, "Coffee shop, red truck, down street, fire hydrant." And she wore sunglasses and she was just like, and everybody loved her, but she could, I mean, we treated her, but that was her new baseline and she was never going to get any better because it has all, it just, it has went on for so long. She's probably never going to be any better than that. And that
So
was sad.
is it congenital, or is it drug induced, or is it what causes this to occur?
Schizophrenia. I think for her, it was definitely hereditary because we also saw her in genetic. Her brother was also in the same ward with the same thing, but luckily he wasn't too far gone as her. So we were able to help, you know, him at an earlier stage. But for her, the prognosis was really poor. She needed help with everything. And half the time she didn't even know where she was or what was going on. She would just be saying a bunch of random words, and that was her sentence. That was her baseline.
Please keep going. This is terrific. Thank you.
Yeah, no problem. So how would I treat this patient? Of course, an antipsychotic, of course, counseling, referral, because people who do have psychotic disorders can do counseling. It's just we have to get them stable enough to the point where they can go to counseling, depending, like we were just talking about prognosis, where they are and when they decided at one point to seek care or they were brought in for care. Case management, definitely case management. I want to have wraparound services for this patient, just so I have multiple eyes from multiple disciplines on them, making sure that they get in everything that they need, even down to primary care. So it's a very interdisciplinary type of thing, multidimensional, multispecial, like everything. I want to make sure this patient has everything that they need. And more than likely, I would probably put this patient on a long-acting injectable and injection because of the severity of schizophrenia and how it can affect the person's life. If they don't take medicine and they do have another episode, how they're losing executive functioning. And so I would probably want them on a LAI. I think the longest one we have now is Invega Half-a-Year. So that's Invega Sustenna, Invega Trenza, Invega Half-a-Year. They only have to take this injection twice a year, but of course they have to start on the oral and we have to work them up there. But I think that's a wonderful option because I don't want to depend on the patient to actually take their medicine and be adherent. People will start to feel better and stop taking their medicine. I think that's the most frustrating part.
Rashada, several questions are popping up about substance abuse and schizophrenia. Does substance abuse complicate the management of schizophrenia?
Of any disorder, yeah, because I have to see them at baseline. So now I have to detox them if there's something that I can even detox them off of. LSD, ecstasy, marijuana doesn't really have a detox protocol. So I have to go ahead and empirically treat the disorder just to try and get them halfway stable while also doing drug screens and adding in confirmations to see how much is in their urine or their blood, or if they're really stopping or telling the truth, or if they need to be detoxed. Like sometimes I don't have a choice but to treat them. But if I can get them detoxed before so I can see them at baseline, ideally that's what you would want to do, because you got to know whether this is purely substance abuse or psychiatric, but sometimes it don't always end up that way.
You know, Rashada, marijuana being in the States, and I'm not being prudish at all, but there seems to be a pretty strong link between marijuana use and schizophrenia now. What are your thoughts?
Yeah. You can flip yourself into psychosis, and especially if you have the genes for bipolar disorder, and marijuana already make people dissociate. I mean, and people don't think about it as a chemical. They just think about it as grass or being natural. But I'm like, it is a chemical. It does affect your memory long-term, and it does deplete serotonin. So everything that I'm trying to do, giving you antidepressants and giving you SSRIs and serotonin reuptake inhibitors, you're depleting, they're fighting each other. You're doing the opposite, and then you're coming to me and you're like, I'm still depressed, I'm still anxious. I'm like, unless you stay high 24/7, you're going to feel withdrawal effects, your appetite's going to drop, and then I have to clean that up. And so for those patients, I give them a time limit and I watch them. But if they can't be adherent, some of those patients get referred out because it complicates their treatment.
This is wonderful, discussion, because you are right on the front line trying to take care of folks who find themselves in the complex milieu of what we call life, yes, especially with the changing laws in different states. Marijuana is not legal in Texas, but it's legal in 30 states now. And and how we help folks in ways that we really don't necessarily have good answers for. Would you agree with that?
Yes, I agree with that. And kratom and all this other stuff, and these kids and all the things we have to deal with. And the parents are upset because they're getting drugs at school. And I'm like, it's everywhere. It's everywhere. What do you do?
We just got a note from Brian, who said he works for the medical cannabis industry, and he's been worried for a long time about the cavalier attitude the industry has in comparing cannabis to legitimate medicine. Any advice for the future to the 300 plus people about pot?
You keep cutting in and out. You said any advice?
Oh, I'm sorry. Any advice for the future about cannabis, about marijuana in the future?
Yeah, so there's a lot of people. I mean, let's keep it, let's be honest. I mean, everything is about the almighty dollar, honestly. And so I would just say, if you're going into medicine and you worked very hard for your licensure, be very cautious about what you choose to get entangled up with, because the last thing you want is to be standing in front of a medical board trying to explain your actions and your reasoning for this, and this. If you can't document adequately and have evidence to back you up, I probably wouldn't do it. Knowing what I know, I wouldn't get caught up in that, but I know some colleagues that actually work for the cannabis people. They actually give people the prescription to take it to the dispensary to get the stuff. And they just hand it out to everybody because that's the hot thing, and we just collect the money, and a lot of them are self-pay. But I think that's a very slippery slope. I don't play with my license. I work too hard, too many sleepless nights, too much stress. I don't have time for that. The Texas Medical Board is tough. It's tough to even get your license in Texas, period. So I don't want to lose it to something like that. Or being that it's not legal here, but just any state, you wouldn't want to lose something that you work hard for and you're still in debt paying back loans. I wouldn't do it. I wouldn't do it.
Well, this is wonderful. So what's next?
Oh, next. So I just put a little quote because this is the end. I put, if you're working on something that you really care about, you don't have to be pushed. The vision pulls you. And that was by Steve Jobs. And when I was going through PA school, and that goes back to your why and your personal statement, that's what always kept me going, is my why. For me, it was my grandpa. He died of heart complications and kidney failure and you name it, encephalopathy, you name it. Dementia. So he had everything you could think. But whenever I thought about giving up, I could see my grandpa in your father, in your son, in your brother. And I would think about my future patients. And I was just, I got to keep going. I got to keep going. There's people out here who need me, the impact that I'm trying to bring to medicine. And so I feel like if you have a dream, no matter if it's PA, nurse, wherever, CNA, stay focused on your why. And I promise you that'll never disappoint you. You'll accomplish your goal, and it'll take you so far. And your patients will really appreciate you. And they, like I said earlier, they can always feel, if you're judgmental, but they can always feel real compassion and empathy as well. And they will appreciate you so much more. So keep going, stay focused on your vision, and don't give up. Yeah, really don't give up. And
I think the important thing is that you have to develop your own vision, don't you think? Rashada?
Yes, you do.
You
You
gotta
really
you gotta
do.
figure out what you think and what you want.
And what you want, yes, what you want to get and the impact you want to leave and your legacy and all the things. But once you got that together, you just got to stay focused. You can't get distracted by social media and other things or disappointments. You just got to let it roll and keep rolling. You just got to keep going. Yeah.
So
And
you are at the Resilient PA. That's tremendous. Rashada, what a wonderful talk you gave tonight. Ali, do you have a couple of questions for
and I
Rashada?
spelled resilient wrong on the website, but y'all know how to spell resilient. It's okay.
We'll figure it out.
I think they'll find it. They'll find it.
You'll find it.
Ali, let's do maybe two more questions for
We'll do two more questions. All right.
Going for over an hour.
Yeah.
Please.
So we'll start off talking about a bunch of students that want to know more about PA school. What do you recommend college students do to prepare for PA school? As in, like, how should they study for the GRE? If they should take the GRE or the PACAT, or like what scores they should try to go to? How much shadowing? Just like, just an outline, just a bare outline would be good enough for them.
I would definitely say it all starts with where are you applying, because so many schools, each school is different as in their prerequisites. Some schools don't even require the GRE. Some schools, very few schools have implemented the PCAT because it's so new. I don't think that they know what to do with it yet. And so I think, and especially since COVID, they have waived the requirement for the GRE because some testing centers, I mean, it's only but so many people can test at a time and they don't have availability and all that stuff. So pick your schools first. Go to the admissions website. If you don't understand what you're reading, call. I tell my mentees all the time, you can call them 5 times a day. Make them know your name. Make them remember you. That's what you want. But also, that's why they're there. You contacting me, asking me, what do you think I should do, is not going to help you because I'm not on the admissions committee for the school. That's why they put the number in their email up there. Please don't hesitate to call the school. That's why they put their information on their website. If you have any questions about their particular program, ask them, call them, email them, and you can be annoying because that's what you want. You want them to remember your name. But yeah, I would definitely say for the GRE, take it as early as you can. Know the minimum score that should be on the website for the school, your minimum, the bare minimum, because I don't do well on standardized tests. So that's what I made, the bare minimum. But know that, know your strengths, know your weaknesses, and know where you should put all your attention at. For me, it was math. I know some people do great in English. It just depends on where you fall. GRE for Dummies is a great resource, like I said before, and with the book comes a website where you can do practice questions on the computer, and also Magoosh, and they have a website and an act where you can do plenty of practice questions on the computer and your phone anywhere. But when it comes down to it, it's less about like the information and more about how you answer the question. I've learned that over the years, and especially when I took the boards. Do you understand what the question is asking you, and do you understand how to answer the question? So I think doing more questions more than anything will get you prepared. Just practice, FirePoint practice questions. All right. But yeah.
So Jocelyn, are you taking mentees? Are there folks, and we have 340 people signed up tonight. I mean, would you be willing to hear from people from time to time? And
yeah, that's why I put my email up there. Yeah. And then when you go to my website, theresilientpa.com, it has more about like my program is called Dreams Inspire Life, Dreams Inspire Life on Instagram, dreamsinspirelife.com. You can read more about my mentorship program, but even like we have a cohort going on right now and we end in June, but even if you can't apply for that, I have a DIY, and it's basically do it yourself program package. And it's basically do it yourself on your own time, watch the videos. We give you templates and outlines for personal statement and all the things, and you just do it on your own time, but then you got to be disciplined enough to actually do it. But it only costs probably like $20. And my mentorship isn't expensive. There'd be some people trying to get over on the internet, charging like over $1,000 to help you get, I'm not about that. I don't do it for the money. all the money that people pay, I think my mentorship program is like $100, but then the DIY is $20. It goes right back into the program. So nothing is pocketed. And even the mentors that I have helping me, the PAs, they do it for free because they enjoy mentoring and giving back. So check us out. Like I said, Dreams Inspire Life, the website, on Instagram and stuff, and just reach out, email me and let me know.
Rashada, thank you so much for that. We do the same thing here. We don't charge anything for virtual shadowing, and we've raised some nonprofit funding along the way. But we do this because it's the right thing to do, and kids seem to appreciate it, and it seems to help folks advance their future programs.
Right.
Rashada, thank you so much. My goodness, what a great program!
I enjoyed it.
Ali, do we want to go give them the slide that shows them the exam? Next slide.
Next one. All right, there he is.
One more. Yeah, there we are.
Yeah, right here. So this is the information for quiz number 94. You can just scan the QR code right now, or you can look on the chat. I'm pretty sure Aditya is just spamming that link, so go ahead and click that. Also, we're going to email you the link later, so if you can't get it now, just keep your heads up when the email comes. It will be due on the 12th of April, and y'all get 2 attempts. You got to score 70 or higher to get the credit, and make sure you save that certificate so you can keep track to yourself how many hours you're getting. And with that, I think that's all we got to do for today.
Yeah. Ali, let me interrupt just only to say, Rashada, Rashada, thank you so much. You had over 300 kids tonight with you. Roughly around 5,000 will view your talk online. Each one of them, of the 5,000, will become a medical provider. And let me ask everyone tonight, please put thank you so much into chat so that Rashada can see it. Rashada, keep your eye on chat there.
Okay.
And each one of the 5,000 will see 100,000 patients in a career.
Yes.
5,000 times 100,000 is 500 million. So Rashada, tonight, you've touched 500 million lives. And my goodness, what a wonderful thing.
What a wonderful opportunity. Thank you guys for thinking about me. And I appreciate all of you guys for taking time and listening to me talk and go down rabbit holes. But I truly enjoyed it. And if you have any questions that you still wanted me to answer, please don't hesitate to email me. I enjoy this. I enjoy helping people and giving back. So please don't hesitate to reach out again.
Well, Rashada, you are a great public servant. And on behalf of you and the whole working group team that you've had the pleasure of meeting earlier this evening, we want to thank all of you for coming. We'll be here next week. We're looking forward to many more weeks to come. And as long as you keep coming back, we'll be here. So on behalf of the whole team, we wish you a good evening.